Hey everybody, it's Dr. Robert Woodbury. Today we're going to do a little talk on hiatal hernia and the repair of it. Now, a hiatal hernia is where part of the stomach goes up into the chest. Other terminology includes paraesophageal hernia, diaphragmatic hernia, congenital diaphragmatic hernias. That's all kind of what we're talking about. I'll start by, let's go over some of the normal anatomy. So normally, this is the food tube, the esophagus. So normally we swallow food down, it goes through the esophagus, right down through the chest, and then it empties into the stomach. Now the esophagus is mostly in your chest and the stomach is in the abdomen. And the thing that separates the chest from the abdomen is the diaphragm. We drew that here. That's the breathing muscle. Now there's an area in the diaphragm that's a hole, and that's what the esophagus goes through. That's right here. That's called the hiatus. So that's the hiatus. The area here is called the lower esophageal sphincter. That's called the LES. We call it LES, lower esophageal sphincter. And again, as we swallow, the esophagus has to pump food down. The lower esophageal sphincter opens. The food goes through. And the sphincter then closes behind so that the stomach juice doesn't turn right back around and come up into the esophagus and cause reflux. So this is, also we know that the spleen is connected to the stomach right there, and that plays a small role in all this. And this is the normal anatomy. So far so good, right? All right, let's do a hiatal hernia. So in a hiatal hernia, the esophagus then comes down, but now there's a bit of the stomach up in the chest. Y'all see that okay? So the hiatus is torn open and the stomach, this stomach right here, is pushed up into the chest. So there it is. Now some hiatal hernias are real tiny or small. We call them sliding hiatal hernias. Sometimes if a lot of the stomach is up like that, it's called a type 2 paraesophageal hernia or a type 3 paraesophageal hernia. This is all what we're talking about. Now the problem with hiatal hernias is they can contribute to reflux. Now just because you have a hiatal hernia doesn't mean you're going to get reflux. And just because you have reflux doesn't mean you have a hiatal hernia. But in people that have really severe reflux and a hiatal hernia, we start talking about surgery to correct it. So when you think about this situation and what we have to do surgically, we'll go through kind of the steps to that. So, repair. First thing we got to do is get the stomach out of the chest. So get the stomach down. Get the stomach down. And that usually means cutting down some of the attachments. It doesn't just come on down. We kind of cut the attachments and bring it down. Sometimes if the esophagus is short, it won't come all the way down, and we have to cut the corner out of the stomach. So for example, let's say we get this most of the way down. So we've got most of the stomach down, but there's still a little blob of stomach up there. We don't want to leave that blob up there. We'd rather just remove it, which is called a gastroplasty. It's also called a wedge fundectomy. It's like a callus type gastroplasty. So all that's to say, if we can't get the stomach all the way down, then we cut the corner out of the stomach to make it into a tube. And that's plus or minus. Plus or minus, we call that a lengthening procedure. Lengthening. You might, again, the words are callus and fundectomy, which just means cut the fundus out. There are other terms that you'll hear me use also. But so now we've got the stomach down, plus or minus a lengthening procedure. And the next thing we have to do is rebuild the diaphragm. So I'm going to get rid of some of the extra here. Part 2 is we rebuild the hiatus. So that hole, which is normally nice and tight, the esophagus goes through it, it's airtight and watertight. So it gets torn loose and we got to rebuild it. That can be done with simple sutures, and the sutures are permanent sutures. And sometimes we have to use a mesh. Now the mesh that we use would be absorbable mesh. It provides strength and scaffolding. Again, we don't know till we get there whether or not we'll need the mesh. Plus or minus mesh. And remember, this mesh that we use is absorbable. So now we've got the stomach down. Let's see, we've got that down. And we've got it looking back where it needs to be. Behind this now, the hiatus is rebuilt. Plus or minus mesh. The mesh kind of goes like this. It's behind all that. So we've got the hiatus rebuilt. And now most of the time, not all the time, there are some circumstances where we would maybe not do this, but almost all the time we add a fundoplication, I'll get to that word, to reinforce the lower esophageal sphincter. We reinforce the LES. Remember, the LES is involved in keeping reflux from coming up. So we swallow down, the lower esophageal sphincter opens, and that prevents the acid from coming right back up. So we want to reinforce that lower esophageal sphincter. And the way we do it almost all the time is we take this floppy part of the stomach, and it's loose, and we can detach it from the spleen. So we detach it from the spleen. Both of those organs tolerate that really well. Sometimes the spleen has a little low blood flow to the top that's self-limited. It just gets over it. And we take and we wrap this stomach around the lower esophageal sphincter. Now I'm going to draw this a little different for you. So we're going to make it like an inner tube, and it ends up looking like this. So again, this is called the fundoplication. That's the floppy part of the stomach wrapped around the lower esophageal sphincter. There it is. And it kind of supports it. This is called a Nissen fundoplication, or a 360-degree fundoplication. So Nissen, you'll see those words. It's 360 degrees. It's a complete fundoplication. Here's that word, fundoplication. I'll put that over here too. Fundo, because it's the fundus of the stomach, plication. Now, some people, their esophagus does not pump strongly. It's weak. And there's a test that we run called manometry, and I'll get to that too in a minute. When the esophagus doesn't pump strong, we don't usually use the full fundoplication. We use a partial one where it's open in the front. It's a little less strong. So in that case, you see how this fundoplication meets in the front. The partial fundoplication is open in the front, so there's a soft spot to help the esophagus pump through. This is called toupee. It's 270 degrees. It's a partial fundoplication. And the way we decide is with a test called a manometry. In the manometry, the team numbs your nose up, and there's a little very skinny catheter that does have to go down, and you end up swallowing it. People get through this, don't worry. And then it measures the pressure waves of your esophagus as you swallow. And that lets us know how well does your esophagus pump, and is there any reason why you need a partial fundoplication. So the finished product in all of that looks something like this. So now we've got the stomach out of the chest, we've rebuilt the hiatus, and we've reinforced the lower esophageal with a fundoplication. Now the technique we use to do this is with little incisions. It's called laparoscopy. And if we pretend that you're lying on your back, the incisions, like if this is your belly button right here, here's your legs, the incisions are something like this. 5 or 6 of them, about less than an inch. If I were to need to get my hand in there to feel something that's very unusual, and I couldn't even predict to you what that would be, then we would use the old-fashioned open incision. Up and down like that in the upper abdomen. So that's called open. So laparoscopic or open if needed. The surgeries, depending on the size of the hernia, a patient may need 2 or 3 days in the hospital. And the next thing we wonder about is what about diet after surgery? I generally recommend a progression of liquids to thicker liquids, then puree diet, then regular diet. And that progresses over about 4 to 6 weeks, depending on, again, the size of the repair and how well the patient's doing. I would give you those instructions at the time of the hospital. Most people take a week or 2 or 3 off work. Again, it depends on the size of the hernia. Most people feel fully recovered by about 4 to 6 weeks, something like that. Now, we do need to talk about the risks of surgery. Nobody likes to talk about the risks of surgery, but there are risks. They're small, but they're real, and we need to go over them. So everybody's got this in their mind now. We're gonna put the risks back over here. Okay. Pain and infection and bleeding, like any surgery. Infection risk, 1 or 2%. Bleeding, we always lose a little bit of blood at surgery, but major hemorrhage would be 1% or less, so small numbers. The other thing is damage to the organs that we're operating on. Damage to the organs. Some of that might be perforation. We use what we call bougies to size the repair. The instrumentation is harder than the tissues, and I do a lot of this work, so I feel pretty confident about that, but there is a theoretic risk of damage and perforation from the surgery. The other thing is, after you reconstruct all this, there's a theoretic chance of having trouble swallowing. So the risk of having trouble swallowing is why we go through a eating plan where you start out with liquids, thicker liquids, full liquids, puree diet, etc. Almost everybody can adapt to these. Very rarely somebody is not able to adapt to the anatomy, and we have to do further treatments, dilatations, and even theoretically a return to surgery to convert and open the wrap up. Very, very, very uncommon. Can't even quote you a number about that. So that's how we handle trouble swallowing. Persistent reflux. So I tell people these surgeries are pretty darn good, but not perfect by any means. And also, we're not trying to get the person to have zero reflux. In fact, I dare say most all of us have some heartburn and reflux every now and then. You take some Tums and that seems to be the normal condition, right? Some people go into this kind of surgery hoping to get off medicines, and I tell folks, we don't know that you're going to get off your medicines. We know that by doing nothing and you're on the medicine, then you're going to stay on the medicine, and then surgery does offer you a chance to get off the medications, but you don't know until you get there. There are some patients that have what we call Barrett's esophagitis, where even if the surgery really helps their reflux and they feel great, we really recommend staying on their medications until they see their gastroenterologist for follow-on endoscopy to see if the Barrett's is getting better. There are some other reasons to stay on medicines as well, just depending on the patient's progress. But we tell people, don't go into this thinking it's going to get rid of your medicines. There's a really good chance, but you may still need it. I put the next title as mechanical problems. You can have a recurrence of hernia. In fact, there is one great study at the University of Washington that looked at their long-term data, and these were expert surgeons at hiatal hernia, and about 50% when you have a hiatal hernia bigger than 6 centimeters are going to get a recurrence. Now, most of the people that get a recurrence still feel better than they were before surgery, and some small percentage needed to have revisional surgery. So why the recurrence? I think the biggest reason that these things recur is because every time you swallow and every time you breathe, you're going to stress this surgery. After all, we're talking about the swallowing tube and the breathing muscle, the diaphragm. It's also one of the reasons why we do things like the lengthening procedure and the mesh reinforcement of the repair to try to decrease that recurrence level. So we can have a recurrent hernia. Again, very real chance of this. We can have just breakdowns of the wrap. And other mechanical problems. It's an area, again, every time you breathe and every time you swallow, you stress this surgery. Catastrophes. Fatalities, super rare. Mostly around medical factors, but there is that theoretic chance. And also, as we talk about the risks of surgery, this is not the complete list. There are other unforeseen, unpredictable problems that can come up. Unforeseeable, unpredictable. Now we trade the risks of surgery against the benefits. The benefits, decreasing the amount of reflux, maybe decreasing those medications, maybe even getting off the medicines as well. Also, when you have big hiatal hernias, the stomach can twist itself shut, which is one of the feared complications of having a large hiatal hernia. So the surgery will decrease that risk and doesn't make any of it go away. And so we balance the risks of the surgery against those benefits. And when I see people in the office, I spend a lot of time going over this based on individual factors. So I hope this helps remind you all. Maybe you've already seen me and I've told you to go to this video to review it, or maybe you just found this. When we talk about surgery for a hiatal hernia, we talked about what the hiatal hernia is. We talked about things that need to be considered for the repair, some of the testing that needs to be done, the manometry and other testing. We talked about surgery laparoscopically with the little incisions, maybe need a big incision. We talked about some of the predictable risks and some of the unknown, unpredictable risks and catastrophe balanced against the benefit. So I hope this helps you all, and have a great day.